Well, I want to thank all of you for joining us on today's webinar. My name is Bill Arnone. I'm the Chief Executive Officer of the National Academy of Social Insurance. We're very excited today to host this webinar on disability policy today and tomorrow, lessons from the pandemic and implications of long COVID. This webinar is part of the Academy's ongoing multi-year Pathways to Economic Security campaign, and today's panel of speakers really brings an extraordinary breadth and depth of knowledge on aspects of disability policy. The Pathways work that the Academy is doing has two major goals. One is to identify the many gaps in our ecosystem of economic security in the United States by elevating the perspectives of key stakeholders who very often have been left out of policy formulation discussions. Our second goal is to draw on the very best quantitative and qualitative research, especially the unique insights of these stakeholders, so that we can identify and assess effective policy solutions. Toward the end of last year, the Academy issued our landmark report called Economic Security for the 21st Century. This report provides a comprehensive overview of the many challenges we face in the overarching goal of ensuring economic security for all individuals and all households in our nation. This report identifies four what we call policy pillars of economic security: labor, benefit, protection, and equity. And it really is the framework for building what we believe is a necessary, better system. The report provides over 100 policy options in all four of these categories. We present them as policy options, not recommendations, so that those of you who are advocates and on the front lines can take these, pick the ones you think make the most sense, and we would hope then advocate on their behalf. Our website has the full report, and in the chat, you'll see a link to that report on the Academy's website. Now, today's conversation will focus on a major aspect of benefit policy, namely how we provide income support to people with disabilities. And I trust there will be no disagreement with this statement that the current process for receiving benefits is both burdensome and time-consuming, and among applicants who are approved, the benefits are typically insufficient to meet existing needs. And I trust we can all agree on that premise of our discussion. If that weren't bad enough, COVID-19 pandemic made things even worse. So now we face a crucial challenge. How will the system respond to and treat those suffering from what we are calling long COVID and starting to see the dimensions of it today? Now, before I hand it off to our panel, I'd like to remind you, if you're able to, register for the Academy's annual Robert M. Ball Awards ceremony, which is going to take place on the evening of Tuesday, October 25th. We are thrilled this year to celebrate three honorees. I hope these are names that are familiar to most of you: Peter Edelman, Marion Wright Edelman, and Jack Lew. All three have had a tremendous and positive impact on social insurance policy and economic security throughout their continued careers. So I hope you'll be able to join us at the Reach at the Kennedy Center for an evening to acknowledge their work and to really come together as a community to look forward to the future. Here, if you want to register, again, on our website in the chat box is a link to register for the Ball Award event. A couple of housekeeping notes. Throughout the panel's conversation, you can engage with us by sharing your thoughts in the chat box, or if you have questions, we have put aside significant time for questions. You can submit them using Zoom's Q&A function at the bottom of your screen. So thank you again for being part of this discussion. And one of our panelists, Nicole LeBlanc, is actually celebrating her birthday today. So we thank you on this special day for being part of our panel, Nicole. So join me in wishing her a happy birthday. Let me now pass the webinar on to Rachel Good, who is our moderator for today's discussion. Rachel?
Thank you, Bill, and good afternoon, everyone. Thank you for joining us. I just wanted to take a quick moment to thank the Academy and Bill and all of you for having me here today. When Rebecca Vallis asked me to do something, I tried to do it. So I appreciate her thinking of me for this opportunity to talk about benefit policy and improving access for those with disabilities. As many of you may or may not know, I've been with Mr. Hoyer for 9 years on November 4th. When I've had a number of policy issues that I focus on. Now I'm his senior health advisor and with also a focus on Social Security policy. But I've had a number of roles throughout the years, but one of the most consistent roles I've had from day one is being his disability staffer. And I've learned a lot over the years from him and from many of you and from all those in the disability community, whether it was fighting a direct threat to the ADA in HR 620, pushing for an elimination of subminimum wage to be included in our Democratic minimum wage increase bill, or whether it's making sure that President Biden's big infrastructure plan includes access for people with disabilities. So this policy, as you know, spans all the spectrums, all of the committees, and I rarely come across someone in an office that really focuses on disabilities, and I think that's something that we can all work to improve on the Hill, something that we can work through our members and education, and I know you all have helped with that, but helping to have a staffer that focuses on disability and can span all of those different issue areas is going to be key in helping to improve policies for people with disabilities. And that's what we're here to do today. And I am by no means the expert on these issues, which is why we have a great panel of experts today. So with that, I will introduce Lisa McCorkle. If you could introduce yourself.
Sure. Hi, everyone. Thank you so much for having me here. My name is Lisa McCorkle. I am a person with long COVID and also the co-founder of the Patient-Led Research Collaborative, which is a group of patient researchers who have long COVID. We conduct research on long COVID and we advocate for better research and policies for people with long COVID and all disabled people. We formed back in April of 2020, so very early on in the pandemic, after a group of us who were experiencing prolonged symptoms after getting COVID joined the Body Politic Long COVID support group. We ended up conducting the first research on long COVID, and since then have been pushing research into the illness forward since then. Including by now, we have a research fund where patients are choosing what research to fund. We're doing a qualitative study on long COVID's impact on employment, as well as a study on reinfections, both on how it impacts long COVID and if people, looking into whether people develop long COVID after reinfection if they did not develop it after their first infection. So those are just some of the projects we're working on. We have a lot going on. And my background personally is in public policy. It became very clear to me early on and to many of us that COVID generally and long COVID specifically were highlighting and exacerbating many of the cracks in our system that disabled people have been facing for a very long time, including having difficulty accessing disability benefits, difficulty getting accommodations, and being neglected by our government agencies. So we work to, in addition to our research, we work to advocate for better policies for people with long COVID, people with related post-infectious illnesses like myalgic encephalomyelitis, and all disabled people. So thank you for having me, and I think I will turn it over to Carlene.
Hello, everybody. Carlene Ponder, Director of Disability Rights and Housing Policy for the ARC of the United States, where we focus on people with intellectual and developmental disabilities. Prior to joining the ARC, I was an attorney advisor with the Social Security Administration for 10 years, directly working on disability cases and regulations and a lot of the issues that I now see on the other side as a policy advocate. And I'm also currently in my current role with the ARC, I'm co-chair of the Housing Task Force for the Consortium for Constituents with Disabilities. We call it CCD for short. And I heard Rachel mention a condition that I'm very familiar with. I have chronic fatigue syndrome. And the only good thing that I can say is all of the interest in long COVID has sparked more awareness about chronic fatigue syndrome or myalgic encephalitis, which I really don't say because it's such a, that for people with chronic fatigue syndrome, that's hard to say. And a lot of the symptoms are the same. And so I'm very interested to see what happens with the research that goes into long COVID for people like myself who've sort of been in the shadows with chronic fatigue syndrome. So thank you so much for having me today as a panelist. And let me see, who am I supposed to turn this over to? Am I turning it over to Nicole?
Nicole is next, the birthday celebrant.
Good afternoon, everyone. My name is Nicola Blank. I live in Silver Spring, Maryland. I'm on the autism spectrum. I'm a policy wonk. I wear a gazillion hats. Look at the impact of the pandemic on the lives of people with disabilities. COVID-19 has been especially deadly and causing complications. People with Down syndrome, for instance, have some of the highest risk of death and severe outcomes. Back in 2020, right as this was beginning, it was a very anxiety-provoking, scary time. During that time, March 2020, March 13th, which was a Friday the 13th, I suffered my first panic anxiety attack because it was so overwhelming, not knowing at the time, okay, how is this spread? Is it air, surfaces? And given the politics of the world, it was chaotic. And some of the things we've seen, like back beginning, it wasn't people with disabilities were, often, sometimes denied ventilators and denied access to staff in the hospital because they would rate, your life, is less worthy than somebody who's, normal, able-bodied. As they'd like to say, this pandemic has brought out, the pandemic of ableism and racism in our society and how inaccessible it is at times. When we look at the silver linings of this pandemic, the best thing is that, it allowed, people with disabilities to work from home, do telehealth, do schooling, all of that online, move everything to online platforms, which has been very beneficial for the immune compromised and high-risk populations. Prior to the pandemic, many of us were told that, you can't work remotely. That was a common accommodation request that was often denied. For instance, I used to work in state government where I was, forced to take Metro Access paratransit. If anybody's ever taken paratransit in this region and in country, paratransit is lousy service. They often show up and pick you up 2 hours or so before you need to be at XYZ. They're often too early, too late. and you can spend upwards of 4 hours or so a day just on a van, even if your, let's say, work site is only 30, 40 minutes away. In terms of vaccine access, in the beginning, many of us struggled with, getting access to the vaccine, having to navigate inaccessible online websites. We also saw great inequities. Me, in my case, I was able to get the vaccine through an agency that's right down the street called Seek. Because I know people, I have a high profile, I'm well connected, because first I tried calling my primary care doctor. They said, oh, call 311, which of course, nobody picks up lines. Oh, and they say, oh, go on this website, it's inaccessible. And then finally pick up Seek, call somebody, send an email to somebody at Seek, here, fill out this paperwork, we'll take care of you. That is one thing that wasn't great when we look at the vaccine rollout. One thing that would have been better would be to do something like Dr. House calls. Back in the 1930s, up roughly 40% of all primary care doctor visits were done via house call. Having nurses, doctors come to our houses, giving the vaccine to disability provider agencies to hold massive clinics, independent living centers, that would have been a better strategy than strategy that was used at the beginning of this pandemic.
Nicole, thank you so much. I believe we're going to have more of
and
that.
Also, and lastly, also
turn it over to Allison.
Some of the resources in the chat, according to a Vermont doctor who opened a practice called All Brains Vermont, long COVID is a risk factor in neurodiverse populations. And lastly, with the Social Security offices being closed, many people with disabilities had difficulty dealing with benefit issues. I got a $23,000 overpayment that I'm fighting.
Next. I'm going to jump in here to do my introduction. My name is Allison Sprana. I am a disability activist in Fort Collins, Colorado. I'm passionate about bringing my lived experience to the table in healthcare, research, and public policy circles. I have myalgic encephalomyelitis, chronic fatigue syndrome, that was triggered by a virus I got 8 years ago. I worked as a community health worker for Colorado's Medicaid program before my disease progressed, and at age 25, I applied for and was later approved for SSDI. When the pandemic started, me and my community saw long COVID coming from the beginning. I reached out to Body Politic in May 2020, which at the time was a New York-based queer feminist wellness collective that became an early grassroots response to long COVID when their founder wrote about their experiences as a 26-year-old person with a lengthy and unpredictable recovery from COVID-19 during the early spring COVID-19 outbreak in New York City. I'm now on the board for Body Politic, which is now a health justice organization breaking down barriers to care through a global network of COVID-19 patients, chronic illness allies, and disability advocates. There, I help lead our moderation team, facilitating peer support for over 12,000 people in our high-quality dynamic discussion forums housed on Slack. And one of the primary goals that I had in reaching out to Body Politic and doing moderation there is to help people with long COVID navigate their disability benefits, time away from work, understand their disability rights, to make sure that they got the services that they need as soon as possible, because it took me way too many years to access them. And as a board member for Body Politic, I also do help advise on policy changes to improve access to both care and benefit programs for chronically ill and disabled people. Relevant to our conversation today, I was a contributing author on the Long COVID Survival Guide, where I specifically helped co-write the chapter on financial survival with long COVID, talking about how to access benefit programs, disability benefits, as well as home and community-based services. With that, I'll turn it back over to Rachel.
Thanks so much, Allison. And I think Nicole already started us off on this conversation, but I wanted to ask the rest of the panelists what your experiences during COVID have been, and what some of the struggles you've had, and what the change in our entire society has impacted you. And Carlene, I'll turn it over to you first.
Thank you. Thanks, Rachel. So I guess first I kind of want to talk a little bit about the impact of the pandemic on the housing situation for people with disabilities. As an advocate for people with intellectual and developmental disabilities who were disproportionately likely to be diagnosed with COVID-19, especially at the height of the pandemic, the pre-existing shortage of affordable and accessible housing was just, exacerbated by the pandemic. So what we saw was people in congregational facilities and settings with more than 6 people, where you could not safely or reasonably social distance, were more likely to be infected by COVID-19, particularly at the height of the pandemic. If you all remember, the reports coming out of places like nursing homes were pretty devastating in terms of the numbers of deaths for residents, but also for staff, because you have to remember, those places are staffed by people who also have families, and we're not necessarily able to safely socially distance as professionals either. And, we saw a disproportionate number of people with disabilities being isolated in congregate settings at the height of the pandemic. Some of that had to do with our policies, sometimes forgetting about people with disabilities. For example, community workers, people who could have connected people with IDD, for example, with services in the community, weren't considered personnel who, would have gotten early access to PPE, I guess we were calling it at the time, things that would have made it safer for them to go in to facilities and interact with residents. That didn't happen until much later on in the pandemic. So we saw a lot of isolation. We saw people who perhaps could have qualified for transition out of congregate facilities into housing in the community, but with no effective way to go in and get them the information, or for them to communicate, sort of what was happening, or maybe what their needs were outside of the facility. That isolation, and combined with like the breakdown in services, for people outside in the community, lack of accessible housing, lack of transition strategies, that kind of thing, all really worked against people with disabilities at the height of this pandemic.
Thank you for sharing that. Lisa, do you have anything to add?
Yeah, just echoing what Carleen was saying. I mean, ultimately, disabled people have experienced a lot of neglect and disregard for our lives over the last few years in particular. Long COVID has been minimized since the beginning. As long COVID patient advocates, we've had to push really hard to be seen and to be acknowledged by our society. And despite now impacting well over 19 million people. And I think the reduction in protections, including the removal of mask mandates, are a good example of how things have only gotten worse since the beginning of the pandemic. It's made society less safe for people who are high risk, and also has increased the number of people that have been disabled by COVID. So I'll leave it at that for now.
I'll second that.
Okay, Nicole, did you have anything else?
And also in regards to rental assistance, for instance, many of the rental assistance programs, the only way you could access it is if you tested positive, or somebody was, or you had reduced income due to COVID. That, it didn't allow for somebody, let's say, like, for instance, I used to live in a 3-bedroom, 1-bath. I moved twice in this pandemic. First time when, my house friend moved back to Chicago, and I ended up moving into a 3-bedroom, 1-bath, just random room as well, in a month-to-month lease where, one person bowed out at the last minute. So I ended up getting stuck paying somebody else's rent. I also encountered, roommates, they stay 3 months and then they don't give, 60 days notice, 60, 90 days notice. This pandemic has been an excuse for people not to give 60-day notice and leave people like me stuck paying somebody else's rent. We need better access to, rental assistance, universal basic income, more having ongoing stimulus checks would have been nice to absorb the cost. And, and you look right now with, mask mandates going away, the world is less safe. My father, recently had it and he's like, it's definitely worse than the flu, given that I've been saying, until this becomes more like the common cold flu, masking and wearing masks N95 is the new normal in my book.
Absolutely.
And it makes some of us less anxiety provoking if we would just spend, keep doing the mitigation matter and invest in ventilation and get better vaccines. Hopefully they can block infection and make this no worse than stomach flu, common cold. That's when COVID will be in the rearview mirror, when we can treat it just like the cold flu.
Absolutely. Allison, did you have anything you wanted to share about your experience?
Yeah, I just wanted to note briefly. So I have been high risk this entire time because my illness all started with a virus. I don't want to know what happens if I add long COVID on top of it. And that has been happening to our community of people with myalgic encephalomyelitis. And so my husband and I have had to be extremely cautious during the entire pandemic. And it got to the point during the Omicron surge when he was forced to go back to work that he had to leave his job and become my primary caregiver through home and community-based services because the risk was too high for me. And so our financial sacrifices that we have made again and again and again through the pandemic, we have no savings left, and we have had such high costs during this time that the only reason we have been able to make it this far is because I have family support, and it should not be that way. It should not be the way that only people with access to privilege can make it through. So, and I know that there are a lot of other disabled people in my community who are in the same boat, who have had a lot of extra high costs because they have to continue isolating because their communities won't protect us.
Absolutely. So, sorry, I was muted there for a second. So you kind of started talking about this, Allison, but the CDC report recently asserts 1 in 5 individuals who have been infected with prior strains have experienced long COVID. And maybe we can talk about kind of what that definition is and how that differs from just having COVID and how that ties into the conversation we're having here today. Allison, you can go first.
Sure. So I think it's important to understand long COVID is an umbrella term. It's all encompassing of things, symptoms, diseases that happen after COVID-19. It doesn't mean it's one specific type of long COVID. There is about half of long COVID we suspect now is myalgic encephalomyelitis. But again, remember, long COVID is this umbrella term, so it could also be inclusive of post-ICU syndrome, organ damage, other things going on. And it's relevant to the conversation because if you look at that 1 in 5 number, according to the Household Pulse survey, that was 1 in 13 of all adults in the US. So it is a mass disabling event, what we are living through right now. And the thing is, it's still continuing because people are still getting long COVID from infections they're getting right now, today, yesterday, last month, the previous 6 months. Is still happening as we go forward. And there are no FDA-approved treatments for long COVID. There's no diagnostic markers for long COVID in objective evidence. You cannot go to your provider and say, I think I have long COVID. Can you run a blood test for me to see if I have it? Nothing like that exists. And so we have to learn from the body of knowledge that existed for invisible illnesses like myalgic encephalomyelitis before the pandemic to know how to research long COVID, how to treat them, and how to determine disability determinations for them as well.
Thank you so much. And Lisa, I know this is your particular focus, so anything to add?
One of the things that we documented in our research was that long COVID encompasses over 200 symptoms, with every system being impacted. The three top symptoms are fatigue, cognitive dysfunction, and post-exertional malaise, which is where you have new or worsening symptoms 12 to 48 hours following any type of exertion, cognitive, physical, emotional exertion. And so it's really an illness that can impact everything, though. I mean, there's new allergies, palpitations, tremors, loss of vision, gastrointestinal symptoms. So it's really wide ranging and is more of an umbrella term. But what we do know is how much it can impact people. So in our research, we found that 45% of our respondents in our survey had to reduce their number of hours if they were working before getting sick, and another 22% were unable to work at all. This is reflected in a few other surveys. So we're seeing that, we know that this has a really big impact on people's ability to work and sustain their livelihoods. But we're also seeing that it's an illness that a lot of the regular blood tests that doctors perform are coming back normal. X-rays are coming back normal. But that doesn't mean that, people's are able to continue working and continue doing chores around the house. So those tests are not reflective of what people are actually experiencing. And again, like Allison was saying, about 45% of people with long COVID meet the diagnostic criteria for myalgic encephalomyelitis. About 2/3, I believe, have some form of dysautonomia. These are illnesses that have been established that we can learn from, that we have, some tests for that show abnormal results. But there has been a severe lack of medical education on these illnesses throughout the last few decades. And so a lot of providers don't know to do those tests, to even consider those diagnoses. And so when people with long COVID are looking to apply for disability benefits, they often, are faced with medical providers who are not educated on what they're actually experiencing, and so have difficulty getting approved for those disability benefits. I think it's really just shown a light on how illnesses that are not well known within the medical community need to have we need to have a better system for dealing with that when we're looking at people applying for disability benefits, and not needing to rely on a diagnostic test or a biomarker as research is developing.
Amen. And also look at alternative medicine. This pandemic and this long COVID epidemic is a perfect time for alternative medicine. Functional medicine is about treating, what's the root cause, not just the symptoms. Because as somebody with autism who's, had line issues and stuff, and has had, gut issues, quite often I've had experiences over my lifetime where doctors say, everything's normal, and yet you don't feel normal. But when you go, see a naturopath, they'll say, you have suboptimal thyroid, let's say. And also we're also seeing, we're also seeing, people that have never tested positive, showing up with gut inflammation and GI docs. We need naturopath alternative medicine to be covered by private insurance, Medicaid, Medicare. It's time to move away from just the traditional way of medicine. Like acupuncture is one thing that's been shown to work with long COVID. And I happen to see an acupuncturist who sees a bunch of people with long COVID.
Absolutely. So that's a great segue into our next question, which is, now that we've kind of laid the table, and appreciate all of you sharing your personal experiences with that, let's talk about how this is going to impact policy going forward. We'll start pretty general. How do you see this impacting policy? What do you expect from us in Congress? What do you expect from the administration? How can we do better?
I'll go. Well, in an ideal world, I would like to see, universal basic income. This pandemic has exposed the need for universal basic income. If we had universal basic income, particularly like 2000 during this pandemic, it would definitely reduce the mental health impact and stress of this pandemic between all the cost of work from home, PPE and associated medical costs that are coming with long COVID. We need universal basic income. We need no strings attached. Like when we look at Social Security disability insurance, we have asset limits, we have all or nothing cash cliff, where if you go over $1, let's say, of SGA, which, for this current year is $13.50, I believe, and let's say Social Security doesn't discover you went over SGA after all impairment related work expenses, subsidies are taken into consideration, you could be hit with, 10 plus grand in overpayments. Going over SGA 1 month should not equal that. Public benefit living with a disability, being disabled is expensive, especially when the regular medical system ignores us and does not meet our needs, and when we can't tolerate nasty side effects as somebody who spent 27 years on epilepsy meds only to find out my seizures are psychogenic, non-epileptic, caused by past trauma, PTSD, which leads to spending loads of money out of pocket on things like acupuncture, zero balancing, massage, craniosacral. It's time to think we have, a universal basic income system and a disability system that's easier, less, make everything easy, accessible online, no strings attached, universal long-term care without IQ limits. Currently in Maryland, I do not qualify for HCBS, even though I have deficit in adaptive functioning. Yet in Vermont, because I had, deficit adaptive as somebody with an autism diagnosis without intellectual disability, I was able to get waiver services. Down here, there's nothing, there's no case management. Case management and home and community-based services should be universal for everybody. We should be able to, even if we have to, buy into it, pay a small fee a month. And that way we get, the support we need, housing, job coaching, employment support, case management, and medical support.
Thank you
And we
so
need to
much.
move
And
away
we'll get to
from
HCBS
settings.
later. Yeah, we're going to have a conversation about HCBS later. I appreciate you bringing that up. Carlene, you haven't spoken in a while. Do you want to talk about maybe some of the policy implications of the pandemic and long COVID going forward?
Sure. Yeah. And I was enjoying the conversation. I mean, I 100% agree with functional medicine being the way, especially for chronic fatigue, ME, and possibly long COVID, and the fact that functional medicine, providers generally they don't participate in insurance, so you have to have some money to access these types of medical providers. So, speaking of policy implications. So I started by talking about the impact of the shortage of housing on people with disabilities, and particularly the impact that had on people with intellectual and developmental disabilities who were left in congregate settings at the height of the pandemic and suffered a disproportionate number of infections and deaths. So, but it's a whole package. It's not just one thing, because if we want to move people out of congregate settings, then we have to have the housing available to move them into. If you're on SSI as a person with a disability, housing may not be affordable, particularly if you want to live on your own. And even if you do happen to find housing in the community, well, you may need home and community-based services. And again, you may be in a position where you either have to pay for home and community-based services, or if you're eligible for a Medicaid subsidy, then that could take years, quite frankly, just like it could take years to be approved for SSI or other Social Security disability benefits. And, the other thing is with public housing, I think only 5% has to be designated as accessible. That's a very small percentage of the nation's public housing allotment. And so, you can have people on a wait list for housing for 20 years. It's not uncommon. And that of course means that people with certain types of disabilities may be relegated to living in an institution, because that's the only place that they can get Medicaid funding to support them. So, we have to look at policy solutions that do more than one thing. It has to be a holistic approach. Another program that we support here at the ARC is called Money Follows the Person, which can help people in congregate settings transition out into the community, into community housing. But that's, it can be complicated to apply. It's a grant program. Not every state, I think, participates in Money Follows the Person. And again, in order to participate in Money Follows the Person, you actually have to have housing available in the community for people to be able to go to. So we got to look at funding housing. We have to look at accessible housing and making sure that we're putting money into the development of more accessible housing. We have to look at increasing public benefits like SSI. The plethora of waivers and grant programs through Medicaid can sometimes be incredibly complicated and can often function as barriers to getting people the types of assistance that would be most beneficial to them. So streamlining as much as we possibly can between the federal government and states who administer these programs. The wait list for public housing, the wait list for home and community-based services, those are all functions of not adequately funding programs that support people with disabilities. So, we've got to put the money in all of these programs in a very holistic way to really make an improvement in these types of issues that we're addressing today.
Thank you so much. Lisa, did you have something you wanted to add?
Yeah, just really quickly. I mean, I completely agree, Carlene. And I think there's so many policies that we currently have that we want to improve for disabled people. There are so many policies that we need to be added to improve people's with disabilities lives. But I think in addition to all of that, we also need to, in every policy that we consider, have a disability justice lens. Right now, we're centering too much people who are non-disabled or really pre-disabled. And that leads to these effects of people who are disabled or become disabled not getting the resources that they need. And so if we start from the get-go at having that lens, we're going to have people who are disabled who are going to be better served in the long run. So it's not just, additional policies that we need to tack on. It's really every single policy we have needs to have that disability justice lens.
Absolutely. Allison, any last thoughts?
Oh gosh, I could spend an hour on this alone myself. I do just want to put a plug in. I think there is completely insufficient help for all disabled people who are applying for disability benefits, and that's inclusive of people with long COVID. It's especially urgent now, given the situation that we're in. We need more assistance to help these people navigate applying for disability benefits, applying for home and community-based services, especially with long COVID. Given that they have post-exertion malaise, it's an energy-limiting chronic illness, right? They exert themselves on any mental or physical activity, and they crash and have severe flu-like symptoms after. I am in this boat myself. I know what it's like. I was privileged that I was formerly a community health worker, and I also had help from my Center for Independent Living when I was applying. We need to wrap these people in supports to help them navigate the system, to help them apply, because it's too difficult right now. And the policy changes that need to happen to make it easier to access, those need to be happening, while in the meantime, we provide the support for people to navigate through the system.
Thank you. And that kind of leads into our next question beautifully. I think a couple of our panelists mentioned that accessing these disability benefits is very difficult, and then figuring out who is eligible and how to navigate that is also very difficult. So if we could just take a moment to talk about eligibility and access and what needs to be improved there. I'm well aware that we need to do more funding from the congressional side, but what else could we be doing to kind of improve access and make people with disabilities who are struggling with all of these issues, make their lives just a little bit easier?
Well, make the Social Security website more accessible. That sounds hard way to say this, but the post office USPS website is easier to navigate than the Social Security website. Have universal case management, develop, approved funding for a case management organization specifically focused on long COVID type disabilities, and universal case management for all people with disabilities. We need universal paid leave, paid sick days. The era of going to work, with a cold or whatnot should end. Like, even with this whole 5 days mask, 5-day quarantine, there's still people that are contagious after that 5 days, still spreading the virus as much as the CDC doesn't want to hear it, but it's the truth. We need to pay people to quarantine, let's have hotels, like I would have had hotels that way you reduce the spread amongst a household, even though they say, household spread doesn't always, if you, take the right step, you can avoid it being a super spreader. Like, my mother avoided it when my father had it recently at the end of summer. Make it so we can do everything Social Security online, like currently when it comes to, things like IRWs and parent-related work expenses, we need to expand that and make it so you can send all your receipts online, make it easy to apply for Medicaid, easy websites, not have to deal with, faxing, running around. We don't have printing and faxing, everything, we're in the digital age, everything should be able to be done online, just, having that option, both old school and new school, and make it so we can do stuff without leaving the house.
Thank you.
Just
Anybody
get rid
else?
of benefit cliffs altogether. No asset limits, no disincentives.
So I'll chime. Oh, did you? Oh, I'll chime in from two perspectives. From my own, personal perspective, as somebody who has, what you call an invisible disability, which is chronic fatigue syndrome, and having a former career with the Social Security Administration, it's very, very difficult for people like us to make a case that we are not capable of doing everything to the extent that one might look at us and assume we are capable of doing, because it's the, traditional medicine has lagged behind so horribly in developing markers or even awareness or recognition of certain diseases, chronic fatigue being one, long COVID, of course, now coming along. So it just, just in terms of even having what you would need to document the fact that you're unable to work more than a 20-hour work week, or you do need an accommodation in your housing because you cannot handle stairs or something like that. Those things we have just a distinct disadvantage in, because we don't even have the initial development of what you would need. I mean, you can't just, I can't just call HUD and say I have a disability. That's got to be documented. They require certain medical documentation. So, just encouraging more, I guess, awareness and research in terms of these types of barriers for people who have certain disabilities, being recognizing that these are barriers that may prevent somebody from getting access to accommodations that they do need. And as a housing advocate, I mean, some things are just common sense. We saw recently that there was an Office of Inspector General report out of HUD, Housing and Urban Development, agency that talked about the problem, the widespread problem that agency had with making reasonable accommodations for people who requested them. I think in one locality, the particular housing agency was very good at actually processing somebody's reasonable accommodation request, but then sat on it after that. They may have even have approved it and said, we're going to, make this accommodation that the person has asked for. Maybe it's moving to housing at the front of a building that's closer to the parking lot, something like that. But there was no actual follow through. And there were people who actually died waiting for their accommodation to be acted on. And so, one of the things that I have done in conjunction with my partners at the Housing Task Force of CCD, the Consortium for Constituents with Disabilities, is we've engaged regularly with HUD officials on these issues. And we have, asked them to make sure that persons with disabilities and these barriers and these process barriers are not sort of a forgotten part of how the agency does business, but rather is at the forefront, because that's what comes across when you see a widespread failure like this in an agency occurring across the country, is that people with disabilities are just kind of forgotten. It's part of agency process. So that's what I'll contribute to this point. Thank you.
Thank you. Anybody else before we move on to the next question?
Yeah, I'll just add in. I am really hoping that we can shift away from how we are currently approaching eligibility and approval processes, especially in the context of these invisible illnesses and illnesses like long COVID, ME, chronic Lyme. It's really difficult to have the correct quote unquote documentation in order to qualify for these benefits. And I am hoping that we can move more towards a system where we're relying more on patient report and, self-reported symptoms, self-reported impact on life. An example of this that I think is useful to think about is that, one of the key symptoms of long COVID and ME is post-exertional malaise. So if you exert yourself, you're not going to see the after effects of that for 12 to even up to 48 hours. So a lot of times doctors are doing tests, they're trying to gauge people's functional limitations. They're not seeing the results of pushing people in that moment. That happens hours, if not days after, and can often lead to people being, in bed for weeks after that, or even permanently making them worse, depending on how bad the exertion was. And so I think it's really neglectful of our government agencies to risk people's health by requiring documentation. Ultimately, sometimes those tests can really push people and make it so that they're suffering for a long time. And we shouldn't be needing that when patients know themselves, like, I'm not able to work given in this current system. And if I'm not getting accommodations, or even with accommodations, I'm not able to work like I used to, that should be enough. We shouldn't need to make people feel worse and potentially risk long-term and even more disabling effects, just in order to get support that they need.
Amen. Disability starts with the environment. As the World Health Organization says, a person is more or less disabled based on their interactions within the environment. And then we have the ADA definition and the federal definition of developmental disability, which is much broader than, the definition for all these public benefit programs. Those are the definitions we should be using to define disability. Disabled does not mean disposable, and if we all live long enough, we'll all join the disability club.
Absolutely. Okay, I'm going to combine the last two questions since we kind of already covered the housing piece. But I did want to return to the conversation about home and community-based services. We are very proud to be able to increase the federal match to states in ARP for HCBS. We unfortunately were not able to include it in IRA, although it did pass the House in BBB, which we were proud of. We know that this is, crucial to helping people live independently outside of the home, outside of institutions and in their homes and in their communities. And I'd love to hear your experiences with the program. Again, any improvements we can make other than funding, since we know that that's crucial, and any other experiences that you would like to share with HCBS.
Well, in the area of home and community-based services, expanding who's eligible would be one thing. In addition, we need to expand self-direction programs that allow people with disabilities to manage their own services, hire their own staff. In addition, we need to pay livable wages to all direct support providers. This pandemic has worsened way on a scale of 1 to 5, has made the HCBS crisis a 5-alarm emergency.
Allison,
we need more training, like for instance here, like in Vermont, with some of one example they're finding is agencies, that were able with the state budget COLA increases with the enhanced FMAP, agencies that, raised wages to 20 plus an hour are having no staffing crisis, yet everybody else who's not doing that is still having a staffing crisis. We need a livable wage. If the minimum wage grew with CEO pay, it would be 33 something an hour in today's world. And if it grew with inflation, it would be over 24, 25. Staff turnover is traumatizing. Not having services, limits, people with disabilities' ability to work, which right now, employers should be, tapping into people with disabilities to help combat the workforce shortage.
Absolutely. My boss talks a lot about how after we passed the ADA, we should have done more to help people with disabilities get into the workforce. So that was an issue long before COVID, but it's much worse now. Allison, I thought I saw you raise your hand. Did you have something to add? Yeah.
Yeah, I think that if there was ever a time to make changes to HCBS to improve access to it, it's now, because of long COVID. And I say that because we were not prepared for long COVID because we didn't invest adequately in infection-associated illnesses before the pandemic. So we don't have treatments to offer them. We don't have biomarkers to offer them. We can offer very little in terms of ways to improve their quality of life through clinical treatment and testing, right? So what we can do is we know that long COVID comes with deficits in activities of daily living, and particularly instrumental activities of daily living, okay? So people like myself, I did not access home and community-based services until I had been sick for 7 years. And my first year of illness, I stopped cooking because I left the gas stove on overnight more than once. And my roommates got so mad at me because of the safety risk, very real safety risk that it posed, that I stopped cooking. And so how did I meet my food needs for the next 6 years until I applied for home and community-based services? They were not being met. And that's what's happening right now to most people with long COVID, because they have not caught up yet to realize that they need to be applying for home and community-based services, often because most of the time they don't realize that what they're experiencing is a disability. So there's a lot that needs to happen to improve access to home and community-based services. Again, I could talk about it for like an entire hour on itself, but one of the things we particularly need to make sure that we're doing now is helping the newly disabled from long COVID apply for these services and understand how to navigate the system, because it would help improve their quality of life drastically.
Lisa or Carlene, anything to add?
Just to reemphasize Allison's point, I mean, in data that just came out yesterday from the census, 80% of people with long COVID have their activities of daily living impacted. And so knowing that, we have 19 million people with long COVID, 80% of them have their activities limited, like having that support could enable people to stay in the workforce. It can enable them to stop getting worse and, not become severe if they're at a mild stage. So having that support of these services is really crucial. And I completely agree that, we need people to be aware of them. We need people to, have better access to them, and it not be limited to, for example, people who, only have a positive PCR test, for example. It should really be open to all people who are experiencing these limitations in daily living.
Thank you. Okay, so I think it's time for Q&A, trying to keep everything on schedule. So I'll start with this question that was submitted before the panel. The question says, can you all comment on policy priorities for adults with severe intellectual disability who need 24/7 care, program engagement, supervision, and therapeutic interventions? Current policy seems to avoid this more challenging and costly population.
Well, in Vermont, one thing that's, been done during this pandemic is, it's controversial amongst advocates in this, but paying parents. When you factor in, the shortage, and then, not wanting to limit the amount of people that come in and out of homes, and home providers not wanting to do shared living, is paying parents to take care of people, particularly, especially those with more severe disabilities.
And I would say I work for the ARC, and that, the population we represent is intellectual and developmental disability. So I would say that this is where support for direct support professionals is absolutely critical. I know that we have a shortage. The pandemic, was something that contributed to the shortage of direct support professionals, but lots of other issues. Direct support professionals tend to overwhelmingly be women. They tend to overwhelmingly be women of color. As somebody who worked at Social Security, I often saw disability claims for direct support professionals who were injured, on the job. And when these injuries happened, these women were relegated to seeking Social Security benefits so that they could sustain themselves and sustain their families, which says that they are not getting the support that they need from their employers, from the workforce, and they're not valued the way that they absolutely have to be to provide that type of care. So to me, that's where we start.
Thank you.
Okay. We need to stop, the state needs to stop ignoring us. COVID has become almost like an excuse to ignore us in some ways. Look at us as disposable. It's time to stop. Ensuring that boosting the care economy between HCBS and childcare, that would help with the workforce shortage, especially amongst women.
Absolutely. Okay, I'm going to move on to the next question. This one comes from Mark Miller. Question to the panel. Can someone give an overview of the status of SSA consideration of policy and procedures for recognizing long COVID and making SSDI benefit awards based on various long COVID conditions?
I can speak to this.
Okay.
So currently what's happening is the way Social Security determines disability is, are they able to work at substantial gainful activity? The typical way that they did disability evaluations before the pandemic that I think most of us here are familiar with. That's how they're evaluating long COVID cases, right? Just plugging it into their normal procedures. But what we do need and do not currently have is sufficient guidance for how to do disability determinations for long COVID, particularly given that there's not objective markers of the disease. And that kind of gets back to what both Lisa and Carleen have been saying, that for invisible disabilities, when there's not objective markers, we tend to fall through the cracks in this system. And that's exactly what is happening. A lot of people with long COVID are being denied their claims, having to go through appeals process. It's very lengthy. They already lost their income many, many months ago, or at this point, years ago now, and they're really struggling to get by while they wait for their application to be processed.
Anybody else want to weigh in? That was very thorough, so I'm not sure anybody else has to weigh in on that one. So I'll move to the next question. Thank you, Allison. Okay, so this question comes from Laura Hotzel. Are people finding that ADA reasonable accommodation requests for those at high risk to continue telework to avoid the unmasked work environment are being denied, even after having been infected with COVID and having negative outcomes? I'm concerned about creating a welcoming work environment for those who have long COVID.
Well, I know if we look at the data with Great Resignation, we've seen people quitting over, businesses getting rid of work from home. That's one telling sign, generally speaking.
Yeah, I'm not aware of any data on that point just yet. It's a really important one though for people who have disabilities.
Yeah.
I mean, I'm lucky enough. I've worked in environments where I've been able to work from home, but I do remember at the height of COVID, I was still with SSA, and at that time there were only, I think, 4 medical conditions that warranted, work for, if you wanted to work from home, 5 days a week. There were only like 4 medical conditions, and chronic fatigue was not one of them. So I can imagine that for people with certain conditions, long COVID being one, there's quite a challenge in presenting to an employer a reason for you to either have to isolate or to have a mask mandate, because we've seen a lot of places have dropped.
Yeah, and masking definitely does reduce exposure. Like I've been even at events, like I went to somebody's retirement party, and that turned into a super spread yet because of being double masked, and doing the whole hand washing routine every time I come in and out of the house. Every COVID test I've taken is negative, even though I almost in some ways think I've had this without even knowing it.
If I could just jump in really quick, what I have seen in body politic is that among people who have been disabled by long COVID and try to return to work, not everyone's request for remote work is being approved. And a lot of that has to do with the stigma against invisible disabilities. I've heard of people's bosses saying, oh, that's not real, you don't need that, which is an obvious form of discrimination, right? But these are people who are taking every ounce of energy that they have just to survive. They don't have the energy to then fight a discrimination, case. And so there needs to be more.
We need funding for lawyers to fight discrimination cases in this long COVID era. And it's time for us to stop, stigma. Like one thing I hope comes out of it is stop stigmatizing mental health. As somebody here who's, has had panic attacks and anxiety attacks where it feels like literally you're having a heart attack.
I will say one positive thing in this area, though, is the Department of Labor, their Ask Jan website has done a really phenomenal job spelling out how to request accommodations for long COVID and recommended requests for long COVID based on symptoms. And so I highly recommend both people with long COVID, but also employers who maybe are having workforce shortage issues, review those resources so that they are naturally accommodating anyone who might have long COVID and might not be disclosing it or might not even realize that they have it yet.
Yeah. Also, another concluding thing is recently, back in June, I listened to a keynote from somebody named, I think it was named Tom or Josh Davis, how he talked about looking back on this, and now he's like, we're not going back to 2019, the way we lived in 2019. The business world, everybody needs to accept that. 2019, that normal is gone.
It is. Okay, that was super helpful. Allison, I don't know if you can put that link to the Department of Labor website in the chat. I see that Lisa has shared a link to the Social Security Administration's emergency message on evaluating cases with COVID. So appreciate that. Lots of good content in the chat if you haven't been paying attention there. Okay, the next question, Carolina Ramos asks, are there any policy levers for training medical professionals to better respond to invisible conditions like ME and address implicit biases that worsen outcomes for women and people of color in particular?
I am not aware of any. I mean, if they're developing at the medical school level, but I first came down with chronic fatigue syndrome in I think 2008, and I've only had 2 medical professionals in this entire time who had awareness of the issue. I mean, and so that's an awful long time for me to have to navigate resources on my own for treatment. So I think that would be critical. As I understand it, women are disproportionately impacted by ME, CFS still, and I think women of color, although I'd like to see more information. I have a sneaky feeling that it is something that a lot of us, I'll just say Black women, are probably even unaware of. We don't talk about this being a condition, chronic fatigue syndrome. Certainly, if you've had the medical care that I have had, you will be told it's not a condition or it'll never be mentioned. And you're left, on your own to do that research. And if you don't have private insurance, I mean, you may be left to sort of deteriorate to the point where you cannot get up and function and go to work and do the things that you need to do on a daily basis. As I was mentioned earlier, most of the practitioners who have been out front on this are in the functional medicine or alternative medicine category. And those are people that you have to be able to pay out of pocket, and they're quite expensive. And so that's certainly not something that is accessible to a large swath of the American population.
One thing that is actually being done successfully in this area, which I'm really excited about, I do serve as a patient expert on it. The CDC funded a Project ECHO model for long COVID and fatiguing illness. And so what's happening is they're taking the very few number of experts that we have on ME, CFS, and long COVID type conditions, right? There's so few of them. There's not enough to treat the number of patients that we have. There wasn't before the pandemic. And now that we have millions more, there's not enough. And then we come together on a weekly basis and we train primary care providers at federally qualified health center who are able to treat patients who otherwise would not be able to access these kind of services. And they learn from the experts, including patient experts like myself, on how to effectively manage these patients' cases. We talk about the cases, we recommend, next steps, tests, treatment options, whatever is appropriate. This is a CDC funded project that's going to run for at least 3 years. And I hope that we will be able to implement it because Project ECHO model is successful, and it's a great way to address this issue.
And I'll add in that there's 3 bills in Congress right now that are aiming to address a lot of what we've talked about today: the COVID-19 Long Haulers Act, the Care for Long COVID Act, and the Treat Long COVID Act. And so they do a variety of things, but one of the key things is educating the public as well as medical personnel on long COVID and related illnesses. Another thing is providing grants for legal assistance to help people with long COVID and related illnesses apply for benefits. And then another is providing funding for better quality care, these long COVID clinics that we want to establish throughout the US. There are already some that exist but are severely underfunded. So providing better quality care for people with long COVID and related illnesses.
Okay, thank you so much. And with that, I think our time is unfortunately up, but I just want to thank the Academy for having all of us. To the panelists, thank you for sharing your expertise and also your personal experience. I know that that is not always an easy thing to do, and we appreciate your advocacy and your expertise here. So with that, we will wrap. Thank you so much for a great conversation.
Adios.
Thank you.